Hello, my name is Melanis-ID53. I'm from Greece, and I'm currently doing my residency in the neurology department of Evangelismos Hospital, which is the biggest hospital in the Balkan area. I'm going to present you an interesting case of concurrent central and peripheral demyelination in a patient with MOGAD disease. It's about a female patient, 48 years old, who was admitted to our clinic due to saggy gait and numbness in her forelimbs for the last 1 month. Her medical history was mentioned autoimmune thyroiditis, a diagnosis of Guillain-Barré syndrome 3 weeks prior, and no history of fever or vaccination was mentioned before. At the medical treatment, she was receiving T4 supplementation due to her problems with autoimmune thyroiditis. When she was admitted to our clinic, she was having spastic paraparesis and she was walking with support. Her reflexes were listed in the upper limbs with dominance in the right and the lower limbs with dominance in the left. At the plantar reflexes, there was seen Babinski sign in both sides, and also hypesthesia at T4 dermatoid area, polypesthesia at both angles, and diminished position sense in lower limbs. Finally, she was having problems with mild urinary incontinence. When she was hospitalized in another hospital, she was diagnosed with Guillain-Barré syndrome due to her electrophysiological examination and due to her findings in the lumbar puncture with albuminocytic dissociation. She was treated with immunoglobulin for 5 days. She exhibited mild improvement, and when she was admitted to our hospital, various examinations was done, such as lumbar puncture, where you can see that there are pathological findings, e.g., neurophysiological examination with the emulating type of sensory-motor polyneuropathy, brain MRI, MRI in the cervical and thoracic spine, where multiple lesions of pathological intensity, where you can see that these lesions are confluent, and with contrast enhancement. More examination was done, such as femoral rape panel in CSF, protein electrophoresis, immunological testing, paraneoplastic antibody panel, PET scan, and hologonal banding with antibodies against cooperative 4 and MOG, where most of them were negative, except the antibodies against the MOG in the serum and CSF, where they were found positive in live cell-based assay. Finally, a diagnosis of MOGAD disease was done, and there was administered to the patient intravenous prednisolone for 5 days, and after there was initiated daily 1 milligram per kilo prednisolone. The patient was monitored over a 3-month period, and she exhibited great improvement in her clinical status, where no tetraparesis could be seen anymore, and she could walk without any help, and her spasticity was greatly improved. At the brain MRI and also the cervical thoracic spinal regions, you can see that they're greatly reduced and no contrast enhancement can be seen anymore. To conclude about this case, a few cases of central and peripheral demyelination in MOGAD disease have been reported in the literature. There are some unique characteristics in our case, such as the extensive lesions in the cerebral hemisphere and spinal cord, and also our patient exhibited a steroid-dependent course rather than described in MOGAD disease. Several mechanisms of virus involvement in MOG antibody disease can be speculated, such as the triggering of second cascade targeting MOG antigens in the periphery. And also another possible mechanism could be the expression of MOG in the peripheral myelin in humans, which has been extensively shown in rodents and primates. Thank you very much for your attention.